Good morning, everyone. Today I'm going to talk about novel strategies in advanced interventional cardiology and vascular treatment. My name is Réka Ehrenberger. I'm a full-time PhD student, and my vision is to improve patient care through evidence-based innovative healthcare solutions. And my mission is to provide forward-looking and novel scientific results in coronary, artery, and vascular treatment. Here you can see my specific goals I'm going to talk about today. Mostly I'm going to present the first two projects of mine, which are both with the methodology of systematic review and meta-analysis, and I will briefly touch upon the third study as well. So my first project is dealing with the optimization of the treatment of calcified coronary lesions. But why is it important? Calcified coronary diseases are also called end-stage coronary diseases, and it's not by accident. The calcification in the coronary plaque can clearly define the adverse event rate and overall mortality rates as well. And because of the resistant plaque burden, these calcified coronary lesions require additional treatment modalities, so-called plaque modification techniques or dedicated devices. One of which is the most widely used rotational atherectomy RA system, which is basically a micro drill. After that, we can use a plain balloon, also called a workhorse device, or we can use another dedicated device, so-called modified balloon types. For example, the cutting balloon, which has little blades on the surface of the balloon. But the problem is that we don't really know what kind of device to choose, how to combine them, and when to combine them. So our aim was to examine the safety and efficacy of these devices and the combination of them. So in this study, we compared the rotational atherectomy device combined with either the modified balloon types or with the workhorse devices, the aforementioned plain balloon. We did this with the analysis of the major adverse cardiovascular events rate, or the MACE rate, which is a composite outcome of acute coronary syndrome, repeated revascularization, overall mortality, in-stent restenosis, and stent thrombosis. We also had secondary outcomes, procedural complications as safety outcomes. Our goal with this study was to provide evidence for the most optimal treatment method for moderately and severely calcified cases, leading to the reduction of MACE rate and reduced healthcare burdens as well. Here you can see the flowchart of our selection. We ended up with 8 fully eligible articles for the quantitative analysis. And here is the baseline characteristics table. I wanted to highlight that we had 2 RCTs, the rest of the studies were observational studies. And finally, here are the results of the analysis. This is the result for our primary outcome of MACE. On the left-hand side, you can see the forest plot, and on the right-hand side, you can see the risk of bias assessment results. We use the effect measure of odds ratio, and as you can see, the combination of rotational atherectomy and modified balloon can almost halve the MACE rates. So that group was so that we could see a reduction in the MACE rate in that group. The problem with this analysis was that we could see a quite high heterogeneity, and we did some exploratory analysis and find out that some of the studies included not only severe or moderate cases in the calcification, but mixed. And they didn't report them separately, so we had to exclude them and had to do a separate analysis and only include those studies that included only severely calcified coronary lesions in this subgroup analysis for a clearer picture. And as you can see here, our results can be not just clinically but mathematically significant here, showing that the application of modified balloons after a rotational atherectomy can be really beneficial for severely calcified coronary lesions. Also, as I mentioned, we had 2 safety outcomes, the slow flow, no reflow rates, and also the coronary perforation rates. As you can see here, we couldn't really find any differences between the two groups, which is quite surprising, knowing that the modified balloons are more aggressive treatment than the plain balloon types. So for overall conclusion, we can say that the application of modified balloons after a rotational atherectomy treatment is really beneficial for patients who are treated with severely calcified coronary cases, although not increasing the risk of procedural complications. We also wanted to highlight that there is quite need for objective evaluation of lesion characteristics and the standardization of it, with mostly the inclusion of intravascular imaging techniques. This is the status of our manuscript. This is right now submitted to the Scientific Reports Q1 journal. And I presented this study at the Semmelweis Symposium and also the annual conference of the Hungarian Society of Cardiology last year. Moving forward to the next study, our goal with this study is to find out the optimal timing of left ventricular unloading during VE ECMO treatment. Oh, sorry, I don't know. Okay. So VE ECMO is an often used component of the complex care when it comes to treatment of cardiogenic shock. But the problem with VE ECMO is that it can cause retrograde aortic flow that can lead to negative hemodynamic effects and potentially insufficient decompression. So it's not really surprising that the in-hospital mortality rates are quite high even nowadays, but it's proved that it can be reduced by the left ventricular venting or unloading techniques. These are techniques that can help the left ventriculars work and maybe reduce the mortality rates as well, as you can see here in these figures. The problem is that we don't really know which unloading technique to use, when and how. In this study, we will focus on the when question, and we will compare the prophylactic unloading strategy to the therapeutic unloading strategy, meaning that the unloading technique was only implemented when there was signs of impaired left ventricular function. We will do this by the analysis of several safety and efficacy outcomes, and our hypothesis is that with the prophylactic approach we can reduce the mortality rates mainly. This is the search key I used for the systematic search, and this is our flowchart of selection. Right now we are at the status of our full text selection with my pair Richie. So here is the progress. And last but not least, I want to briefly mention my first published paper. In this paper, we summarized the implementation, the management, and the complications of the VE ECMO in catheterization laboratory in the treatment of cardiogenic shock. We also highlighted a lot of recommendations based on the experience and the practice in our center as well. So for summary, I've presented you my three projects, which are for the goal to optimize patient care and also help practitioners with evidence-based healthcare solutions and evidence-based decision making. I'm confident that my presented and future research can adequately serve this purpose. And thank you for your attention.
I have a question. In your first study, you presented the data on severely calcified lesions. It's absolutely crucial to know what we start with. So, in the articles you pulled for your research, you had 8 articles.
Yes.
And do you have any data on how they confirmed the severity of coronary stenosis? Did they use intravascular ultrasonography, or it can be standardized between them, or you see some heterogeneity in the definitions?
Yeah, mostly, thank you for the question. Mostly the heterogeneity was caused by this discrepancy between the studies, because some of the studies, most of them only evaluated the calcification severity by the use of the angiography, so the coronarography, I think 2 of the studies used IVUS, intravascular ultrasound, and 1 of them used the OCT device. So yeah, it's a big problem, and this is why we highlighted this in our manuscript as well, that we need objective evaluation for more accurate result. Is important not just clinically but also for research purposes as well.
In your first meta, in the safety outcomes, you mentioned that it was surprising that actually there is no difference in safety between the workhorse devices and the modified balloon. Do you think it might be because everybody knows that the plain balloon dilatation is, as you said, an aggressive method, an aggressive intervention, and maybe that's why the investigators took extra precautions to make it safer for the study? Do you think there could be some kind of event like this?
Of course. So as I also mentioned, we only had 2 RCTs. So the choice of device is mostly depended on the practitioner or the choice of them. So of course, if there was a more severe calcified coronary case, then they could use modified balloon because it's a more aggressive treatment. But in the moderate cases, they used, I think, mostly the plain balloon. And we can see the problem here. So this is why we also highlighted the need for more randomized studies. Yeah, so it can be the cause of also in the MACE rate and also in the safety outcomes. Yeah, it's a limitation of our study, but thank you for the question.
What is the clinical practice now in Hungary?
In our center, if there is a severely calcified case, we mostly use the rotational atherectomy device. There is also a newer device I haven't mentioned, which is the orbital atherectomy. It's quite new, and there are some limitations of it. So nowadays we mostly use the rotational atherectomy device if needed. And it is also a choice of the practitioner or the operator. After that, if needed, we use cutting balloons or also some type of modified balloon. It depends on the lesion characteristic, the location of the lesion. But yeah, this combined use of these devices is often seen. Yeah.
Going back, and how often you use intravascular sonography to confirm the result of the first rotablation? Because basically what happens is that you have 2 combined procedures. First you do rotablation, and then you proceed according to the result of the rotablation. So do you use ultrasound?
Yes. Yeah, it's quite a limitation nowadays that so these imaging techniques are quite expensive and time-consuming. But if for my best knowledge, we use these devices in case of left main coronary procedures when it's a really high-risk PCI. So yeah, I think that's the one time when it's really needed, and of course there is the opportunity to use them in other cases as well, but it's rarely seen.